Good morning. My name is Yemi Laosebikan. And if you are around 50, I'm sure you'll be getting a mail from the government on the month of your birthday. You might be needing one of this, so pay attention. So colonoscopy is a common procedure that we do in the outpatient setting, and one of the concerns that patients bring to us is the fact that it's a painful procedure. So most of the people who even get the FIT screen dump it because of the fear of that. One of the ways that we try and abate this is given conscious sedation, and the depth of sedation is very important. But one of the challenges of increasing the depth of sedation is a cardiopulmonary compromise. The ideal medication should make the patient calm without any side effects, but we know that that doesn't exist. We looked at our current state, and most of our patients would get 3 milligrams of Versed for starters, and probably even throughout the procedure. Very few need a bit more, or we give very few more, and they are monitored. And having reviewed our charts, we found that only 1 out of every 3 patients don't experience pain at all. The other 2/3 had some degree of pain, and we were not really helping our patients. So we decided to look at what the problem was. And I can divide this into 2. The first part is with the endoscopist, being the person doing the procedure and also giving the medication. It's difficult to multitask. For fear of a cardiopulmonary compromise, you don't want to give too much, because what if something happens and you have to resuscitate? And to give propofol, you need a second physician who is skilled in using the medication. And unfortunately, being a rural practice, we don't have enough doctors who can avail themselves to giving this. So we took advantage of getting a third GP anesthetist to come and work with us, and we decided to try the use of propofol. The anesthetist got together and could only commit to 1 day of endoscopy, and I decided on the other day I will bump up the dose of midazolam and see whether it was worth calling a second person in. So the goal of the project was to improve patient experience during colonoscopy by reducing the patient assessed pain score to 1/10 in all patients by the end of April. I had a few potential challenges that that were on my mind. The team came up with a few too. One was buy-in from the GP anesthetist, and running that discussion by them wasn't too much of a problem. They were obliged to. They were happy to assist at least 1 day. They were able to move their schedules around, so that wasn't much of a problem. Drug of choice and variations in dosing. All the 3 anesthetists had their preferences, and I couldn't really influence that, so it was another research on its own. We thought there was going to be some cost implication. Probably not much. We just moved resources around to accommodate the changes. We felt that increasing the dose of midazolam will increase patients' duration of sedation and need for observation in the recovery room, and that's a serious concern that nurses brought up, and that they experienced that. Patients with propofol woke up immediately and were ready to go home, but we had policy that said you had to observe these patients for 1 hour. So those who got propofol talked, and the nurses got mad, but we couldn't change that. And also, I learned that using water irrigation to distend the colon was better than air. Trying to learn that in that process was a bit of a challenge, but after a few cases, it became quite easy to do. if you want to know more about the findings of the project, come to the poster. But some reflections. I have 3 things that I just want to talk about, and that is, understanding the concept of change. Before QI, one thing that was constant was change, and it bothered me. Why are we changing this? Why are we changing that? But during this process, I've come to understand that change is going to be ongoing, it's continuous, and to be effective as a leader or as a physician, you have to embrace a change. And if that change is patient-focused, I think you become a good patient advocate. So that's the first thing. The second thing is the PDSA. It took me a while to really understand. I understood the PDSA, but to actually marry what I was doing took me a while, and it was just like a switch. And probably that happened 6-7 months into the course. Oh, that's what I've been doing. Okay. But yeah, QI is ongoing PDSAs, and I think we need to embrace those small changes because they make a big differences. And the third point is QI is a no-brainer. And I saw this picture of a brain with an IQ, and I thought if I put it in front of a mirror, or if I got a mirror image, I'll get a QI, but it's a reverse Q, so apologies there. But the point still is, the higher your IQ, the more intelligent you are, and QI equates, high IQ. So thank you very much.